Good morning, good afternoon, good evening, wherever you are, and welcome to this new TechNet 21 webinar series on EIR or IIS, how to select the best digital immunization system for your country context. Today, we're going to have an overview of SantéIMS as an EIR or IIS with the Tanzania use case. You can listen to this presentation in French or Spanish. To do so, please select the globe at the bottom of the Zoom window and choose the desired language. If you struggle to find it, please do let me know in the chat area. There is a chat area that I've just mentioned where you can already introduce yourselves. That would be very good for us to know who you are, and where you are from. And you can also use this chat box if you need any technical support, and I'll do my best to help you. If you have any question during the presentation, so don't hesitate to ask a question. If you think about something, a panelist says something and you want to ask something about this specific topic, don't hesitate to ask your questions during the presentation. All the questions will be answered at the end, or we hope we have time to answer all the questions at the end of the session during the Q&A session. And finally, this session is recorded and we'll share with you the links to the video as well as the slides. This will be done by email. I wish you all to enjoy this session, and I'll give the floor to Emily, who will introduce the panelists. Emily, thank you.
Thanks so much. Hi, everyone. Good day. Welcome to this third webinar series. Today, I have the honor of introducing our colleagues. I'll start with Madeline Barber-Dalmalen. Madeline is a co-founder of SantéSuite Incorporated and has over a decade of experience delivering complex digital health initiatives, managing software development, and taking digital health products to market. Before joining SSI, Madeline was the lead project manager for the Oscar Electronic Medical Record team at McMaster's University's Department of Family Medicine, where she led integration with Ontario's Better Outcomes Registry Network, maternal, infant, and child health EMR modules. After Madeline gives us her presentation, she'll be followed by John Richard. John is a software development and quality assurance lead at Path Digital Square. He has over 8 years experience implementing health information systems and managing product development, including requirements analysis and design, business process development, software development, enhancing testing and deployment. He has provided support to other African countries outside of Tanzania as they address primary healthcare system challenges through the implementation of digital health solutions and data use innovations. Finally, John Machancharo will assist with the Q&A, as well as myself and Harriet Lest. Thanks again for joining. Over to you, Madeline.
Thank you. Welcome, everyone. Thank you for joining this morning and this evening or afternoon, wherever you're joining from. I'm Madeline, and I'm going to be providing an introduction to SantéIMS and then passing over to John Richard. So today, the format we're going to follow is a brief overview of SantéIMS, and then passing over to the Tanzania use case and followed by Q&A as we talked about. So SantéIMS is a proven person-centered immunization management system. We're going to be talking about the key functionalities overall. So we'll go through those, and then I'll provide a table of the functional requirements, what we cover, and then any considerations for implementation and support, as well as typical implementation timelines, some of the things that shape that, and contracting options available, followed by different cost categories. So, in terms of SantéIMS's key functionalities, SantéIMS is the next generation of the proven OpenIZ Immunization Information System that Tanzania's TIMR is built on. It's designed from the ground up based on the better immunization data initiative, or BID, its requirements in collaboration with the full spectrum of health system stakeholders. SantéIMS works online and offline without loss of functionality or data to overcome barriers such as geographical isolation, internet and power availability, delivering care anywhere it is needed. Its once and done workflow automatically generates person-centered indicator data as a byproduct of care delivery, maximizing data accuracy and timeliness while reducing the burden on health workers. SantéIMS significantly improves data quality. It does this by providing unique ID-based registration through its integration with the SantéMPI master patient or master person index. It provides, through this capability, improved equitable access to vaccines, identifies and reduces zero-dose cases, improves data quality and denominator accuracy, and provides the ability to leverage immunization events to register and update births and deaths. SantéIMS provides seamless integration with different systems, aggregate data tracking and analytical tools like DHIS2, and stock and supply chain management systems like OpenLMIS, MSupply, to optimize the supply chain efficiency, stock management, and minimize waste. Other key functionality include running natively on Linux, Windows, Android, and leveraging existing hardware investments in tablets, laptops, desktops. Its federated deployment model can reduce central server workloads and telecommunication costs. This slide provides some of the proven impact and benefits. So it summarizes the benefits and impacts of the Immunization Information System that have been realized and measured as part of the BID initiative and reported in peer-reviewed journals. So moving on to the functional requirements, SantéIMS checks all the boxes. Its integration with communication tools such as SMS enable communication with healthcare professionals and the public. It comes with built-in automated decision support for vaccination workflows. It also provides intelligent automated scheduling to minimize patient visits and maximize follow-up, as well as automated schedule planning and forecasting. SantéIMS can capture reasons for refusal and other issues. It also provides report generation support at a facility, regional, and national level, as well as individual monitoring. It provides micro-planning support to identify priority communities, to address barriers, and to develop work plans and solutions. It also has built-in data and charting to support planning and monitoring, such as coverage or other indicators. SantéIMS supports automated data aggregations to whatever geographic or administrative level needed. It is open HIE ready, and broad support for open standards are available. For example, GSI1, HL7 FHIR R4, HL7 V2, ICD-10, JSON, PDQ, PIXM, the list goes on. I won't bore you with it. In addition, there's some additional functional requirements. Its implementation of unique ID at registration enables zero-dose monitoring. It is built in graphical data visualization, as well as integration with third-party data analytics and visualization tools. SantéIMS offers a longitudinal record of an individual's vaccine history. It also provides near real-time adverse event reporting. SantéIMS captures the full information on administered vaccines, and it supports traceability of biologicals down to the manufacturers, as well as routine recording of batch information. It supports paper and digital vaccine certificates, and it provides track and trace of vaccines through integration with GS1. So I'm just going to show here some screenshots that show SantéIMS supports continuous improvement through evidence-based feedback loops. And in addition to this, moving on to some of the considerations for implementation and support. So in general, when looking at this, things that we consider would be the existing in-country depth and range of technical skills and capacity, as well as the experience providing different levels of support from Tier 1 help desk to Tier 3 or any necessary infrastructure. So looking at what already exists and where the country is, and as well as what type of support model is best suited based on their needs and challenges. Also looking at things like staff retention, is there turnover? Wanting to create an organizational memory so that if there were ever turnover, that there's solution would be supported beyond that. And then also the other thing we look at is the governance model. And that goes all the way down to privacy and security and other things as well. So it's hard to say in terms of typical implementation timelines. This tends to vary on various different variables. So the number of facilities, the points of care and their geographic distribution, what's currently implemented or if nothing is implemented, as well as the telecommunications infrastructure and what other infrastructure exists. Also local technical skills and capacity and the degree of change management that's overall needed. All of these things impact the timeline for implementation. So it tends to vary depending on where we begin and the journey. Also, another thing to consider is the current technology and whether there is paper-based or existing electronic immunization registry or system and other systems that we would integrate with and the associated data migration or migration efforts. So I'm just going to briefly list the contracting options available. We do offer software as a service, licensing, and a hybrid model. It tends to depend on each situation. And in terms of cost categories, we're not able to share the direct cost categories in more detail, but things that drive the cost categories tend to be an assessment if needed. Also the implementation costs and data migration, training capacity building, and whether or not typically there would be a software as a service subscription and the ongoing support and maintenance. So those are all the cost categories for consideration when looking at adopting SantéIMS. Okay, so I'm just gonna hand it over to John Richard for the Tanzania use case. And I'll go to the next slide.
Yeah, thank you, Madeline. Yeah, I will now take you through the Electronic Immunization Registry, a solution development process for the Tanzania case study. Next slide, please. Next slide. Yeah, so before we share the experience, first of all, I wanted to share some of the challenges that were identified by BID Initiative Project together with the Ministry of Health. We know that routine immunization and new vaccination are two of the best buys in the global health, especially in particularly in Africa. Yet we know that many are still being missed with this life-saving tool. And much of this is due to the fact that we don't have the information of who they are and where they are. In summary, we have some of the challenges that were identified by the BID Initiative Project together with the ministry. Starting with inaccurate denominator. For Tanzania, the source of source used to estimate number of children or clients for each facility is provided by National Bureau of Statistics. However, in practice, the actual number in a given catchment normally vary with from the estimated numbers. If we are uncertain about how many children are needed to be immunized in every month, we cannot truly say that we can measure the success. The other challenge is inability to trace, inability to know or to identify the children that may have not received the full dosing due to the fact that the existing solutions were paper-based So it was really difficult to identify a number of, the children that missed certain doses. And the other challenge is complexity and data collection tools. The complexity of data collection tools and reporting forms really increases the burden to healthcare workers. It also increases the number of errors because they have to record the same data over through the different tools. The other challenge is low data use, low data use capacity. The healthcare workers at the facility, they're normally regarded as data producers, and then when they produce data, they share data to higher level, and the higher level makes decisions. So there are no data use capacity within the facility level. And the other thing is there was a lack of visibility in stock and the consumption data because the tool they had did not really provide the visibility. So it was really difficult to know if a facility has stock out or a facility have enough stock that can be used for certain days. Next slide, please. Next slide. Next slide. Yeah, so, sorry, go back to the other slide. Thank you. Yeah, so I would also like to share the experience in terms of selecting solutions or technology that can be employed for any country. First of all, whenever you are making decision in terms of technology, which technology to use for any program. First of all, for Tanzania, we had digital health policy and strategies requirements that was in place. This tool was referred during the selection process because it highlights this strategic areas and priorities whenever you are selecting the tool that you would like to use in your country. The other consideration is you also need to consider the existing technology landscape to see if the existing technology really support the technology that you like to use. And the other thing is not only the infrastructure or the technology, you also need to look at in your human resource, the available human resource in your country, to look in the technology, the skills, the capacity to see if the technology that you want to bring, they really have the capacity to sustain and support the technology in the long run. And the other thing to also look at is local ICT infrastructure. You also need to look at the infrastructure that is in place. For example, if you want to bring a solution, let's say a mobile solution, you also need to look at the infrastructure to ensure that the infrastructure really support the solution. And the other thing you also looked at is, and this is based on digital health strategy. We also, because their strategy really highlight that they need solutions that can bring freedom to the country, so that they have, they can always keep on supporting. So there was an openness. They were also looking at, we were also looking at the scalability and reusability of the solutions. So these are the guiding consideration. And the other thing also we're also looking at is in terms of integration. Does the solution really can really exchange information seamlessly with other existing solutions in the country? Next slide. Okay, so now I will provide you the overview of the Tanzania Immunization Registry. When we speak of Tanzania Immunization Registry, it's a solution that is built up of different components, which we'll see later on. The component that is currently used at the facility is the mobile disconnected client version. It's a mobile-based version that is used at the facility to register, track, and to collect, track, and monitor the client immunization records. Currently, the solution is used across 3,800 health facilities across 15 regions, and we have also registered more than 2 million children in the system. Next slide, please. Yeah, and in terms of platform, the solution, or the TMA solution, is built on top of an open source solution or platform called an OpenIZ solution. And so TMA is highly customized OpenIZ solution. As you can see from the architecture, the OpenIZ platform provides, it has different components. There is an business or the business intelligence a component for the reporting purposes. There is a OpenIZ application such as administration portal. The web administration. There is also a web version for the district users or the regional users to monitor the performance at these facilities. And then it was also built with the following the OpenHI standard. So solution can, the platform can integrate using the different standard such as HL7, FIRE HL7 standard. Next slide. Yeah, so the solution architecture of TMA, as I said before, it has a different components. There is a TMA component. I think that is an immunization management system, which is responsible for exchanging the information. Exchanging the information with other systems. It's also responsible for the business rules at the central level. It's also responsible for the internal reporting. And the other component is the database part. We have a data warehouse. It's a secondary database, which is a denormalized version of the primary database, which has clinical data or clinical records. This process of denormalization process is translated using the ETL or the ETL process. And then we have the mobile user interface, which is used by healthcare workers. It works offline and online. And then we also have web user interface, and then the div admin or divo user interface used by the divos. Next slide, please. Yeah, in terms of the functionalities, TMA has the core functionalities such as immunization management. With the immunization management, users can record clients' immunization records. They can schedule clients' upcoming vaccinations. And then we also have growth monitoring parts. Apart from the immunization, we also, with the system, we are able to monitor growth, children growth. The weight record is also has a inbuilt decision support, where it's, in case maybe child weight is high or normal, so provide the interpretation to you to the healthcare workers so that they can understand and then provide the advice to caregivers. And then we also have client management part where you can release the clients, the children. You can also manage child records, update the records. And then we also have a stock management part. With the stock management part, you can monitor stock levels at the facility. You can do stock adjustment. You can also request for the stock at the regional level, because the solution is integrated with the Vaccine Information Management System. So you can request the information of this to get a stock refill. And then there is the performance measurement part. With the performance measurement part, as one of the interventions with BID was to ensure that the data use capacity is built for healthcare workers. They can have the capacity on their own to analyze data and then interpret and also make some useful decision at the facility level. And then we also have SMS reminder, where a system can send reminders to healthcare, to the clients in case they missed out the immunization schedule. Next slide, please. Yeah, I also wanted to share the development roadmap. Yeah, so yeah, before the development, for any software, we normally have an inception meeting. For us, we did the inception meeting just to have a common understanding between the developers and between the path developers and the Ministry of Health. Also define the communication and the vision that we are expecting from the vendor. And then there is and we employ the agile development methodology, where we divided the requirement into different, into small pieces in time called sprints, where for each sprint we normally review the work that was done, and then to ensure that it's tested. And then when a solution was ready, we did piloting. For the piloting, we selected a few facilities, and we also considered the different factors like facilities with higher volume, with higher number of children, facility with good internet connection, facility with low internet connection, to ensure that we can test a solution in the different environments. So it is always important to select few facilities, because if you go to the whole country without testing in few facilities, it will be really costly to go back whenever something goes wrong. And then after the piloting, and then system was rolled out to one region was selected. And during the rollout process, we conducted TOT training to ensure that we have the team or resource in place that can train the healthcare workers at the facilities. And then after we gone live, we also had the time to try to keep supporting in case we found out there any bugs or issues, and then it's addressed by the developers. Next slide, please. Yeah, in terms of capabilities, system makes less internet bundle. As we said, it was offline and online, so data is compressed so that we don't use too much bandwidth when you are transmitting the data from the facility level to the central level. And then we also had, system also had on device a server backup in case a system crashes. We have a way to back up data and to restore data And system also works offline for weeks or even a month. So for the facility that is purely disconnected, doesn't have internet connection, they can completely work offline, then find a place where they can synchronize data. And then another capability is it's secured and encrypted local storage. System is also interoperable. We have utilized the existing different integration standards like FHIR, as I said before. So system can seamlessly exchange data with and secure it with any other solution. And currently it's integrated with VIMS, DHIS2, and health facility registry. Next slide, please. Yeah, in terms of lesson learned, I also wanted to share the key lesson learned during the implementation and the development process. One of the key lessons learned during the development process, as we all know, that we are developing solutions for the healthcare workers, for the users, not for the developers. So we make sure that the end users are involved during the implementation process, the development process. So for Tanzania, we formed a user advisory group. The user advisory group is composed by a mix of different users from the facility up to the national level who provide the support. And so whenever we have any release, we share with them, they test, they provide their views. And then in terms of rollouts, we also have lesson for rollouts. It's always critical to roll out in phases because it also gives a room for software improvement. In terms of implementation strategy, we also have lesson learned. For Tanzania, we implement a different implementation strategy. We started with internal, where for PATH, we have implementation specialists who goes and train healthcare workers, but we came to realize it was slowing the rollout process, and then we came up with a different strategy where we, for each district, we formed TOT or district immunization mentors who are trained, and then they go to provide capacity. So this also created ownership and sustainability. In terms of devices, before we roll out the solution using Samsung devices, but we came to realize that because there was due to the device was not that durable, also devices was sometimes being broken because they are somehow sophisticated. Then we came out with a solution where we customized the devices, come up with rugged tablets, which was somehow durable, and it was customized with a government logo. So even it's difficult for someone to use for their own purposes. And the other lesson is it's also always critical to identify the champion or the focal person for each facilities to ensure that, because we know there is sometimes healthcare workers move from one facility to another facility. So it's very important to have someone at the facility who always will provide or transform or transmit the knowledge to other healthcare workers, to any new healthcare workers. So it's very important to have champions who are the key in advocating the solutions. Next slide, please. Yeah, in terms of limitation, I would also like to share some of the limitation. Despite the fact that solution is completely offline, we can also use it offline and online. But first login normally needs internet connection. And the other limitation in terms of stock, as we said, we have integrated with VIMS, but the stock currently, whenever the stock is sent from the regional to or from the district facility level, users are not getting any notification. So sometimes they miss out if they have stock in the system. The other thing is system works offline, but you need, for the facility that are not, does not have connection, you need to find a place where you can synchronize data. Either you go to the district or to any place where you can synchronize data. The other thing is on staff retraining due to the movements. So as we said, we have regional mentors or the district mentors, but there has always been a challenge in terms of staff retraining, because staff are always moving from one facility to another, or some of them just leave their jobs. So it's very important to also keep on training. And the other limitation, it could be a limitation or challenge. In some of the facilities, it was realized that they always depend to some of the specific healthcare workers. So when you visit the facility, they just say, well, we have maybe if that's that person they are relying on is on leave, and then they stop using the application. If you ask, they say that this application is supposed to be used by someone. So I think that's another challenge that also in some of the facilities. Next slide, please. Yeah, I also wanted to share the technology used. This is some of the technology used, and also the skill set needed for the developer or the other system administrator. Yeah, I think this is what I really wanted to share with you today. Yeah, thank you so much.
Thanks a lot, John. So, do we have any questions? I don't see questions in the Q&A box. So, if you have any question, it's now or never. I mean, don't hesitate to ask your questions in the Q&A box. I see someone is raising his or her hand. I would ask our panelists, would you like to take, oh yes, now we have questions coming in. So I will give the floor to, John, I think, to manage the questions. Is that correct, Fred?
Oh, Emily and I can help out with the questions.
Please go ahead, Harriet, go ahead. Thank you.
Thank you. I know Emily did have a question. We do have a raised hand from Badara. So if you did want to unmute and ask a question, please do feel free.
Thanks, Harriet. Can you all hear me?
Oh, yep, can hear you loud and clear, Emily.
Okay, super, thank you. Excellent presentations, both. I wanted to start off our Q&A period with just a very overarching question for John Richard. For countries that are looking to develop their own EIR or IIS, what is your hands down best piece of advice that you would give them?
Yeah, thank you. I think it is Emily. Yeah. Yeah, I think the piece of advice I would like to share to the countries that would like to deploy a digital solution. I think one of the things is, first of all, to because we know there are different existing solution in the market. I think it's not. I would really advise to start developing from the scratch because we have the existing platform like an OpenIZ. Now I think it's upgraded to Sante Suite, and then we also have DHIS2. We have OpenSRP. There are really different solutions that are available. And the other thing is it is always very important to have some sort of maturity assessment. Yeah, you assess the infrastructure, you assess the human resource, so that whenever you are selecting the solution, you have the human resource who are really capable to keep on providing support. And the other thing is also to make sure that the solution align with the vision. Either it's a MOH vision or is it a government vision. I think those are the important piece to be considered whenever you want to select any digital solution.
Thanks so much, John. Those are really great points. There are a few questions that have popped up in the chat. One is, what is the full name of TIMR? And that was answered by our second John. TIMR stands for Tanzania Immunization Registry. And then there was a question as to whether it was based on DHIS 2. And as today's webinar series is on SanteIMS, Madeline has let us know that that's what this platform is based on, SanteIMS. We have a question in the chat in French, and I think we're looking for someone to translate that now.
I can help with that. Can you hear me?
Yes, we can. Thank you.
Okay, that's for the question in French. Well, the question in French is actually more for organizers. That's you and I. Is it possible to organize in the near future other webinars on the installation and practical operation of each application digital platform to allow us to experiment and adopt an appropriate application? That's a rough translation. So practical, I don't know how how is that possible, Harriet? Is it something that is possible to organize maybe at some point?
Yeah,
or
sure.
Is it technically feasible?
I think we could touch upon that. Sure. We definitely want to add to this webinar series, so we can take that into consideration.
Okay, thank you. Right, you can go for the next questions.
Sure, thanks so much. So there's a question from Guillaume there, saying thanks for sharing the Tanzania experience. He would like to know if the solution that's been implemented has replaced an existing immunization information system already used, digital or paper-based. And let me just, his question is to better understand if I think if it's sort of more work for the users or a simplification of their work. So a question about the workflows. So over to John and John on that one. Thanks.
Yeah, so yeah, I can respond. Maybe John can add. Yeah, so the implemented solution, actually the idea behind was to replace the existing paper forms or the paper system. But the way it was implemented, it was parallelly implemented with the existing solution so that we can learn and understand if the solution really addresses the challenges that we identified. So it was a parallel run, and then actually it also brought some of the challenges, especially the workload, because healthcare worker had to work on the two solutions. But the later on, ministry decided to start, after they realized that solution is really addressing the existing challenges. And then the few facilities or few regions were selected. The paperless region, where we tested the paperless. And currently we have testing the paperless in the 3 regions in the country. And we are still learning, and I think it's still in the progress. After we are done with the assessment, then I think it's the ministry decision now to decide if they want to roll out across the whole country. But so far we have 3 regions where we are testing completely a paperless solution. Yeah.
Thank you so much, John. Madeline and other John, do jump in if you wanted to add to that, else we can move on to Emmanuel Bayo's question.
Yeah, thank you so much, colleagues, and thank you so much, John. Yes, as John has replied, it's true that we are actually implementing it to both paperless and paper-based, because we actually running now for the 15 regions that actually running as both the paperless and the paper-based immunization registry systems. But with the current initiative from the ministry is actually testing for these 3 regions to actually work as a paperless immunization registry. And then after the lesson that will be collected, then the ministry is going to decide whether we are going to actually roll out into the rest of the regions to actually use the paperless TIMRI. But otherwise, yes, we are running on both platforms.
Thank you, John. Really helpful. Let's move on to Emmanuel's question, a few questions. I'll read them out, and then do feel free to jump in, John, and Madeline. So Emmanuel would like some more information about how you've addressed the population denominator challenge. We know that is problematic in pretty much all of our countries. A question also about the instance, whether it's hosted locally or in the cloud, and if you have any recommendations regarding that. A question about timelines. So how long did it take from the assessment to the deployment? And then a quite tricky question, how long is a piece of string? Operational costs. So what is the typical operational cost you're sort of incurring after deployment? And have you purchased a license for each user? So maybe over to you, John Richard, to start, and then maybe over to John, and Madeline, do jump in at any point. Thanks so much.
Thank you. Yeah, starting with the first question for the target population denominator. So there are some of the intervention that were put in place to respond to that challenge. One of them was to do registration of the clients that are born at the community. So whenever a child is born, the community healthcare, the village executive officers or the ward executive officers will always register the clients using the mobile phone. So when the information is registered, then information goes directly to TIMRI central database. And the other way is at the facility. So at the facility level, it was really ensured that whenever a child is also born, the information is registered in the system. And then whenever they visit at the facility for the immunization, the information is available at the facility. So it was, I think those were the interventions that were employed. Of course, some of them was not sustainable, especially the registration at the community. So there are some of the interventions that were dropped. In terms of hosting, solution is hosted locally at the ministry infrastructure, at the government infrastructure. And in terms of assessment to deployment phase, of course, for us, it took long because we were also learning. And this is the main reason why we are sharing experience with the other countries, so that cannot go through the same path that we gone through. Because first, before the TIMRI was introduced, there was some of the solutions that were introduced, but we came to realize the solution was not flexible enough to be customized for the country. So we dropped that solution, and then we gone back to the drawing board, and then we came up with TIMRI. In terms of operation costs, yeah, of course, even though it's an open source solution, yeah, there are some of the operation costs because we did not have by then we do not have developers at the Ministry of Health. So whenever there are any improvement or enhancement that needs to be done, we always need to contact the developer or the community who developed the OpenIZ platform. Also, there is a hosting cost, despite the fact it's also the government infrastructure. I think government is also paying the cost. In terms of license, we don't have any license because it's an open source solution. Thank you.
If I may, I was just going to also chime in to add in terms of question 1 with regards to the population denominator challenge. Another thing to consider is that OpenIZ, which is now called the later version of SantéIMS, is based on the same SantéDB platform, which the sister product, SantéMPI, the Master Patient Index, they share the same core platform and capabilities. So essentially, in the background, the immunization system can also leverage the unique identification registration capabilities that the MPI offers. So that's another thing that kind of powers that as well in the background. Over.
Thanks so much, Madeline. Really helpful. We do have, I think, another couple of questions in French.
Sorry, Emily, please. I have my colleagues here, Alex, want to actually chime in on the first part, on the population.
Go ahead.
Hi, colleagues, and thank you for these meetings. Just to add on what John and other colleagues have just mentioned around the populations, and thank you, John, Richard, for clarifying that clearly is that in Tanzania, we faced the problem around the denominators, particularly the number was not realistic. And what TIMRI does, as my colleagues have already mentioned, it does register all the children's. And in the 15 regions that we have already implemented the TIMRI, so we at least in a year time, you'll be able to have a best estimate of those number of children that are born in that particular regions, so that we can try as the tools in terms of advocating. Particularly the challenge we're having is the population that we are using for the immunization services. We are using the National Bureau of Statistics population, and we are binded by that law that the target population, the denominator we have to use is that from the National Bureau of Statistics. So what TIMRIS does, it can give us, which the National Bureau of Statistics over the times it has been challenging and not realistic one. So what TIMRI does, it gives us the exact number of the children that are born in particular year, once all of them have been registered into the system. And we can use as an advocate tools in terms of the exact number of denominator that we can use in future or in the subsequent areas or in that particular regions to have a best estimate of the denominator vis-a-vis those that are coming from the National Bureau of Statistics. Thank you.
Thank you very much for chiming in and for that great information. We have a question from Zozimo, which I think is from Madeline. So is SanteIMS used in the Sahel region, Chad or Mali, for example?
Yes, thank you. So SantéIMS is not used at this time in the Sahel region, like Chad or Mali. We are looking at implementing it in other East Asia Pacific regions, and but it's not currently implemented in that region. Over.
Thank you, Madeline. And Guillaume has added a follow-up question to the denominator question. So how can TIMRI ensure that it captures all of newborns in a year? I don't know if anyone wants to speak to that. Sean or John and colleagues.
Yeah, I think.
Yes. If I can.
Go ahead.
Yes, maybe if John can jump in. Yes, we understand that there are some of the children that are born in the community. In Tanzania, the strong push around the delivery at facility is very, very strong. And now at facility delivery is increasing. We are almost now at 80% delivery at health facility level. But we also have a very good network of the community health workers that are working around the communities. And those children that are born around the community, they are now then referred to the facility for further care in all those early delivery activities. And once they are in the facility, they are now have an opportunity to be registered through the TIMRI system. So yes, we understand there's a challenge in terms of those who are delivering at community, but we have this network of community that they do refer those children to the facilities for further care and also subsequently registered into the immunization system. Thank you.
I was just going to add that also there's this magical moment when infants come into the world where there's a natural point for vaccination. And that's a great place to use as a vector for registering an infant. So I just wanted to add that there's that natural pairing. Over.
Thanks so much, Madeline. We are nearly at time. I'm just a little concerned that we're maybe missing some of Elvis's questions that are in French. So if a French speaker could maybe jump in, we've covered that. Thank you so much, Alex.
Yes, well, one was kind of already answered. So how long will it take to expand this program to other countries?
There is some more at the bottom, I think.
Yes, and yeah, and is it possible to offer this this kind of platforms for free to poor countries to help them facilitate the quick management of data?
I can jump in there and attempt to answer that. So we do, so SantéSuite, we do a lot of work in low, middle income countries, and typically funding and grants come through country demand, but typically there's many development partners and stakeholders that are willing to help fund the implementation or the inception phase. And so we are seeing that there's equal opportunity for that as well. And because the core piece of the software, it is open source. Like there isn't at this time, there's no license cost for users to use it. Mind you, there's other costs associated with delivering the software as a service or support or implementation, what have you. But we do look at this and we do try to focus on providing an equitable access model. So, over.
Thank you so much, Madeline. I think we are at time.
Yes, yes, it's 4 o'clock. Thank you. I mean, 4 o'clock here in Geneva. Thank you very much. Great. So a lot of questions at the end of the day, and fantastic presentation. Thank you very much. This is yes. So this is the end of this session. We would like to thank our panelists. So thank you, Madeleine. Thank you, Johns. And thank you, Harriet, and thank you, Emily. Am I not forgetting anyone? I don't think so. And I would like to thank also our interpreters. And next week we have at the same time, same day, another session on IIS. So we hope to see you there again. I wish you all a very nice rest of the day. And as a last reminder, yes, we will share the slides and the recordings by email. Thank you very much, everyone. Have a nice rest of the day. Bye-bye.